thank you, and thank you all for being here, and especially for those of you joining us remotely. I recognize a lot of the names out there, so welcome. It's interesting, 10, 15 years ago, in various neurologic clinics, people would ask, should I exercise? I've been diagnosed with Alzheimer's. I've been diagnosed with Parkinson's. Should I exercise? And we used to tell them, well, if you want, just don't hurt yourself. And it didn't seem like that was a great answer. But really, over the last few years, we've realized that exercise is probably the most important thing you can do. Numerous studies are showing that exercise can not only slow progression of Parkinson's, it can also help improve memory function. It's so exciting for us in our new location to be able to practice right alongside with such wonderful therapists, physical therapy, occupational therapy, speech therapy, and especially people who have an interest in the population we serve, people who are certified in dementia care as well as in Parkinson's therapies. It's a great way for us to practice together. We get a lot of feedback from the therapists about how some of my patients are walking. I pass by the gym 100 times every day and peek in and often see my patients in here exercising. So I see them in different windows of time, and that helps me make better medical decisions. But it also makes us feel like we're practicing more as a family, and that's what everyone is interested in having, and that's the way we all enjoy doing it. So I'd like to introduce a few folks. We have Kathy Lawrence, we have Sarah Kingsley, and we have Jessica Martin, who's hiding behind the camera. And I'll let you guys sort of introduce yourselves, and really let's talk a little bit about what's different between, let's say, the average powerhouse gym and a therapeutic gym. So without further ado.
Hey, I'm Kathy Lawrence. I'm the director of the program here with Jessica Martin, and I'm a physical therapist. And today we want to share the things that we do here that are different than what you would see at other outpatient therapy clinics or at other, come on in, or at other gyms that you might just go to work out. I'm going to have Sarah talk first because she does have to leave, but Sarah is our myofascial specialist. I'm going to call her that. And she'll tell you about all the wonderful things she's been doing for our patients here.
Hi, everyone. I'm Sarah Kingsley. I've been a physical therapist for maybe over 10 years or so, but it wasn't until just this past year that I started practicing what's called myofascial release. John Barton's trained, and it has completely changed my practice. I have seen chronic pain, neuro conditions, you name it. And, there's exercise is awesome. Stretches are great, but there's only so much that you can do without putting your hands on someone. And so many physical therapy gyms and clinics, and they say, go do these exercises, see you never, or see you in a couple of weeks. Why aren't you getting better? But you need to put your hands on these people. And the restrictions in the body, especially with Parkinson's disease, it makes you so much more susceptible to this chronic tone. It's a sympathetic state is what it's called, this stress, this fight or flight state of mind that not only Parkinson's, but we all in this modern world are finding ourselves in, but especially with Parkinson's, that's part of the disease condition. And it makes it twice as hard. I'm going to go with maybe even 10 times as hard to exercise when that tone is weighing you down. And how are you going to activate the muscles that need to be activated if those other muscles are pulling you down? So what I do is I try to find those restrictions that are holding the body down and release them, so that then when you go to exercise and do your movements, all of a sudden you have access to these new ranges of motion and new muscles that you never even knew could work. And all of a sudden you can stand up taller and you can walk better. And that is what we aim to do for our patients here. And what I want to take it to the world. So thank you all.
Thank you, Sarah. So Sarah is great. And I'm a physical therapist too, but I work more with people and their movements. So a lot of times I send people to Sarah to kind of fix some of their restrictions, and then they can come to me, and then we can move better. And it's really such a great partnership that you're not really going to find at other outpatient clinics. What else is unique about us is that we are neurotherapists. So all of our therapists are neuro trained. We have certifications for Parkinson's, LSVT-BIG, power moves, that you're not necessarily going to see at regular and traditional outpatient clinics. And of course, Jessica will talk about some of the speech therapists, but we have dementia specialists as well. So we've just been working with this population for a really long time. So when you come and see us, you know that you are going to be seen by somebody that knows your condition, knows what's going on with your diagnosis, and we're better able to provide you the treatment plan that is going to take you to that level that you want to be at. One of the things we're really excited about here for physical therapy is our LifeGate treadmill. And I have a wonderful subject here, Beth, who's going to demonstrate. So one of the things we love about having people come to the gym is that we get to use the treadmill. This is really great for people that need a lot of gait training. So there's some gait instability, gait abnormalities with the step length, especially those who kind of have shuffling gait, freezing of gait, or even people with orthopedic condition. We can exercise them on a treadmill, and we have a harness that keeps them safe. And even at sometimes we can lift up some of the weight. So if someone is having some pain or issues in their hip, and we can take off some of that weight, and then they can walk. And obviously there's just a little bit of distance here. So when we get folks on the treadmill, we can go a long distance in a long time, and we can really, really address these issues. And we do some fun stuff with Beth. So she's going to demonstrate for us. So I'll have you hop up. So I hop up. So we have this nice harness that I'm going to tighten up really good. And this harness is what's going to keep her safe, so that it's definitely not comfortable to sit in. That's going to keep her safe and make her feel safe when she's doing her gait training as well. I think that's really important for people not to be afraid of falling when they're doing the training. Okay? Okay. So we'll have you pop up.
I need one of those at home.
The
harness. I need the harness.
The harness. Just take one step forward. There. So we use this a lot with our Parkinson's patients who have breathing of gait issues. The research out there shows and supports that treadmill training is one of the best interventions for freezing of gait. And so this is a great way for us to do it safely. So you can see she's really secure, and she can sit harness, and she can hang, and she's very safe. And this is balanced to give that support. And then so we can get a good view to as therapists, and we can look at the patient from every angle, and we can see where their deficits might be. And then we can work on taking really large steps. We can work on getting the push up in the back and really lifting the feet up and getting that foot clearance on the treadmill, because we can come around all the angles and give them the feedback that they need to improve their gait pattern. And that's really great on the treadmill. But we can also do more challenging things as well. So let's do side stepping. Side stepping. Okay. But we can work on side stepping as well, to really strengthen the legs, and improve the weight shifting in all the different directions that we have. When we have folks who have freezing of gait, destination type of gait patterns, take a little step back. Sometimes the treadmill triggers those behaviors to happen. But then we're able to teach them how to break out of it. So when you start, the feet start going and you can't stop them, we can give them the cueing that they need to break out of it and start taking those big steps and be able to overcome it without the risk that they're going to fall. Now back to the game. In a real therapy session, we don't stop the treadmill, but I didn't want to go too crazy for a demonstration, but we can also do backwards walking. So backwards walking is actually really important. It's an important skill to have and an important skill not to lose. Some people kind of forget how often we actually walk backwards. How often we actually walk backwards in our life, and we just don't think about it until it starts becoming a real stuff. And especially with folks who kind of estimate. Take it on. Way around the corner. Yeah. And then we can make them turn all the way around while the treadmill's moving. That's the fun part. So, and this is just stuff we can't do without the treadmill. So we love the treadmill. So thank you.
You know, what's remarkable is that in traditional outpatient therapy sessions, you always hear people saying, take bigger steps, big steps. But, you know, can you think of any other way to reproduce this where people can take bigger steps in a safe way to train their brain without having this kind of equipment?
Yeah, so when we work with people in the home, we obviously don't have a treadmill. So what we found, so the small steps happen a lot with the Parkinson's especially, but even with some of our dementia and Alzheimer's patients, we'll start taking those shuffling gait pattern. We found visual cues on the ground are really, really successful. So we'll I just marked up someone's house today. I think the wife was going to kill me, but it was so good for the patient. So we put lines on the floor for the step length that we want them to be at. So we'll mark the floor. So then they have to step to the tape, and then they can get there. They can kind of get their bigger steps, and it really works well with those types of patients.
How big? Like 1.5 feet apart, or?
Well, it depends on the person and how aggressive we're being. But a person without Parkinson's who have no neurologic conditions generally has about 2 of their feet.
Parkinson's.
Yeah, with Parkinson's, we try to shoot for 1 of their feet and maybe half.
Okay.
So a lot of times people with Parkinson's only walk like this big, like they don't even really pass their other foot. So we try to get them to at least 1 foot stride length. Some of our patients, and you could see with Beth on the treadmill, she can almost get to that 2 foot stride length. And then when she comes off, we make them do it on real ground, and it translates into real life. And then
I don't
they
mind
take
working
those
at my floor. I'm going to go home and do it.
blue tape today, all the way from the bedroom to the dining room. So, that's one of the things we do to make the larger steps. And sometimes it's just, you have to use different words sometimes for different people. Like some people think big is just this big, but if you tell them take a humongous step, they might go like this. So you kind of have to figure out what works for each person. Just so, great about what we're doing is we've seen so many people. It's like we have this toolbox over here of cues that work, and we just pull out whatever cue we think about and we try it with each person until we find what works for them. So that's kind of my favorite thing to do. Or we put agility dots. They're like these colored circles. We'll put them on the floor too, and we'll make them go in all the directions and just teach them how to take larger steps and feel comfortable with it. Because I think one of the issues that folks have with Parkinson's is that they don't even recognize that they're not taking big steps. So a lot of it is just teaching folks, this is a normal step and this is okay. You can do it. And then they do get better at it. I think that can definitely attest to improved gait with the therapy intervention. So that's kind of some of the stuff we use. We get really creative. All right, I'm going to get back off of here. So I don't know. Yeah, maybe Jessica can talk a little bit. I can talk about occupational therapy. Let's talk about that real quick too. About the rest.
My name is Jessica Martin. I'm the speech therapist. We have 3 on staff here that go either here to the gym or we come to your home. So most of the South Carolina people will be seeing me just because that's kind of my area, but I do see some in North Carolina, so you may recognize me from there. We are also especially trained in working with neuro. I'm Speak Loud certified, and we've got we've got Speak Out, LSVT Loud. We've got different types of dementia certifications. So between the 3 of us, we all have worked with this population, each of us at least 15 years, some of us even more. So we've got a lot of experience with that. Most of us, speech therapy, come to the homes. We work on getting the voice louder. We work on cognition. A lot of times with Parkinson's, we will see difficulty with dual tasking, doing 2 things at one time. So having the brain, so as you're walking, having a conversation. So speech therapy will work on different tasks that will help to multitask. You know that sometimes as you are doing 2 things at once, you'll stop doing one. So we will work on trying to keep that going. We also work on swallowing. As the disease progresses, we do know that sometimes swallowing becomes an issue. And so we are trained in working with that as well. The neat thing that we've just now gotten here at our gym, and I will show you, sorry, can you make sure that is, can you see the, I am too. Oh yeah, I see it. Okay, so this is our new touch-based computer system that works on so many different things. It's all touch screen. We've got different ways to train your brain. Different activities to work on memory, different activities that work on attention. Say, I'm able to see on the screen. So this one lets us see what activities and what things we're going to be working on here. So we're working on the visual spatial, the attention. There we go. So we're trying to touch the ladybug here. And so we're working on looking around the screen. We're working on the spacing, the timing. So, and then it shows a result, and then we can continue to follow and see how it goes as, let's see, executive function. There's ways to
I'm just going to show you a couple because we're hoping to get some people to come to the gym and use this as well. So right now I'm trying to see, does it match the item that was shown to me at the beginning? And so it's working on following directions. We also have different therapy things in here, like move your body. Kathy and I were looking at this one. Now it's actually going to show Melanie.
How's it showing you?
So you see, so I feel that was going to swap.
Yes,
videos.
thanks.
So if physical therapy wants to use this and somebody's got issues with their arm, we can draw that to make it go up. And we can draw this if we want them to reach down. So you can see how we're trying to get somebody, if somebody's got a little posture issue, we're going to work on trying to get them to midline. So it's got some really great tools, different exercise videos. There's some interesting stuff about swallowing. So if somebody's getting ready to go for a swallowing test, we can show them what it's going to look like so that they're not so surprised when they have a swallow test done and they stick a camera up your nose. So we've got different ways to show how we can do different interventions on here. So I'm trying to think what else about the IN2L. So we just started this. It just arrived last week. So we're really excited to be able to use it. Janet and I have used it in the past for many years at other facilities. So we're really excited to have that here.
Well, so tell me the feedback that you guys are hearing from some of the patients.
So trying to think for voice, I find people are really excited. We work together. We do well. They'll go out in public. They'll say, hey, I was at dinner and nobody asked me to repeat myself again. And it made me feel good. Or I went to the deli and I was able to order what I needed from the counter and they did not have to ask me to repeat myself again. And it makes them feel good because it's something in your life. You've got to be able to communicate and have those conversations and be able to make yourself known. And it makes people feel good to get that independence back.
I hear from a lot of my patients just, how amazing your team is. Whether it's the speech, whether it's the physical therapy, whether it's the occupational therapy. And most of these folks have worked with other therapists at different times for different reasons. And whether it's just your communication style, whether it's your expertise, whether it's all of the above, we just hear rave reviews. And I actually see the improvements in whether it's gait or whether it's the speech volume, whether it's the cognition. What you guys are doing actually translates into helping us take better care of our patients. And I see it every day in folks that we're taking care of. So it's definitely just a fun way to practice, and I'm glad to be part of this team that's here. Tell me a little bit about the differences between PT and OT. I get that question a lot.
Yes.
I'm not sure that I answer it correctly.
So PT and OT can be very intertwined, but generally speaking, occupational therapy is really going to focus on your activities of daily living. We call it ADLs. They're really there. How are you bathing? How are you dressing? How are you doing your hygiene? How are you cooking? How are you cleaning? They're really looking kind of at the occupation of your life. But they're also, in our world, helpful with the fine motor control too. So especially with those who have Parkinson's, the hands don't work a lot of times the way that the brain is saying, pick this up and squeeze, and the hand's just not doing it. And they're able to come in and they do big exercises with the hands. So we talk about big exercises with physical therapy, but occupational therapy is doing it as well. And they're also teaching compensatory strategies on how to get dressed. So with our Parkinson's folks, a lot of the complaints we get is that it takes an hour to get ready in the morning, and the spouse is like, it takes forever for them to get dressed. And so that's when occupational therapy comes in. It teaches them how to be more efficient with their movements, tips and tricks on how to get the clothes on faster, and really be able to cut that time down. So physical therapy, we're more about moving and grooving. How do you get in and out of bed? How do you get up from a chair? How are you walking? What does your balance look like? Every patient we work with gets a lot of balance training. So we're kind of more there in terms of the differences, but there's a lot of intertwining. Like occupational therapy is going to work on balance and physical therapy is going to work on balance. It's just we kind of have different goals for it. Ours, PT, is more like, what's your balance like when you're walking down the street? OT might be, what's your balance like when you're in the shower? So we're working on the same thing, but there's a different outcome that we're thinking about. So that's kind of.
And our OTs can go do a home assessment as well, to do like a home safety assessment. So we get that question a lot. Can somebody come in and show us where we should put a grab bar? So our OT will come out and assess how you get in and out of the shower, so that we can say, hey, this will be the best spot for your grab bar. Or they don't like it, but when we come in and say, we got to get rid of some of these throw runs, these are tripping hazards. I know they look nice, but so the OT can be very blunt about that and say, hey, this needs to go. Or sometimes even a chair, your favorite chair that takes 5 times to get out of. Maybe the OT might say, hey, let's try this instead. So the OT can really do that. And that's what's so nice about that we're able to come into your home, is that we're able to actually see in real life how you're doing.
Can I say something?
Yes, of course.
I was diagnosed with Parkinson's several years ago, and one of the first things I did was to find a good neurologist. I got the best here. And we've been working towards trying to keep in check the progression of the Parkinson's. But it does progress. And then the therapy was suggested that I undergo therapy. And I have been undergoing voice therapy, physical therapy, occupational therapy. And I alone have noticed a huge difference very, very quickly in my gait, in my speech, and in my just handling myself on a day-to-day basis. It works. It definitely works. And you need professionals like that to teach you how to navigate. And they're very supportive. I don't know what to do without you guys.
We love you. It's one of our best patients. Hardworking.
We take care of a lot of folks here at Memory and Movement Charlotte who have some cognitive issues. Maybe not so many physical issues, more cognitive issues. And I know a lot of what's wrapped into some of your therapies, what we call cognitive therapy. Can you speak to some of those techniques and how they can help people?
So we, for everybody that we see, we do a cognitive screen to kind of see where they are. And based on that, if they're at a certain stage, we're able to teach compensatory strategies. We're able to retrain the brain. Once we get to a certain point, then we work more with the family on how can they adapt their lives and their approach to help with the cognition. So we really want to kind of find out where the person is to decide how we're going to work on the therapy. Also, language can become an issue with cognition. And so sometimes getting the words out. I don't know if some of y'all were on the Take Charge Live that I did with Dr. Edwards a couple months ago, but we talked about aphasia, and that's where the words may not always come out like they're supposed to. And so we can work on that as well.
And for physical and occupational therapy, cognition, of course, is a important component of how we are treating somebody. So, of course, we have, an amazing partnership with all of our therapists together. But for us, sometimes, if I'm working with somebody and, for example, with Parkinson's, dual task, which is doing a physical task and a cognitive task at the same time, is a really kind of big issue. So then I'll go to Jessica and say, hey, this patient that I have, when they're trying to do something with their thinking, their gait breaks down and they can't walk like they can when they're not doing this task. So then Jessica will intervene on the speech therapy end too with dual tasks. So now we're kind of both working on dual tasks to improve that with this patient, even though it's her territory, it impacts the patient's gait. So it becomes my territory too. That's how we kind of intermix together. It's really, really a great partnership. Or I might ask Jessica, I'm trying to teach this very specific compensatory strategy. Is this patient going to learn it and be able to follow through on their own? Or is it something that, the caregiver is always going to have to tell them this compensatory strategy? And then she'll say, well, based on their stage and our cognitive testing, yes or no. So that works out really well too, because that's very much her specialty. So I rely on her for a lot.
I think another example of what a great partnership it is, and why we love working all together here is, often people are here doing their therapy, and they may experience a certain complication from their Parkinson's. For example, their blood pressure might drop for various reasons, or other things might happen, and because we're right down the hall, often in 30 seconds I can pop in here and see what's happening and actually understand, okay, this is the blood pressure issue that's happening at home. But we always wonder, why is somebody falling when this happens? Is it balance? Is it the blood pressure? What is it? But to be able to collaborate and be able to come and see people in this environment, it's so different than just being in a sterile exam room and you're having the doctor-patient relationship there. It's a much different, more dynamic way to be able to evaluate people. And I think that's definitely what works. But yeah, certainly appreciate all of your partnership. Love working with you guys. So glad that we're all here together. Okay, this is a great question. I'm not sure that I necessarily have the answers, but love everyone's perspective. But talking about Sarah's myofascial program and how beneficial it is for people with Parkinson's, is there a possibility of continuing that therapy sort of on an ongoing basis, especially if the insurance stops paying, or if the client has to pay out of pocket? So how do we sometimes navigate those things?
Yeah, so we get that question a lot, and it's not even Sarah stuff. It's all of the physical therapy. The question is, how can I keep going when maybe the insurance is not going to cover anymore? We do private pay services, but we always have to bill insurance first to get to that exhausted benefit with the insurance. And then if insurance is no longer covered, so especially with the managed care plans, we have a lot of limitations on coverage. We can continue after that on a private pay basis. And Sarah definitely does some private pay work as well. She only works for us part-time. She has a wellness business on the side. And we do allow her to see clients if needed on a private pay basis when the insurance doesn't cover anymore. But we kind of have to follow that. We bill insurance first, and then after that, we move to a private pay type of situation. But insurance does get hairy sometimes. That's for sure.
Just sticking to the theme, this one last question about the insurance of I guess individuals had some challenges with the PT getting denied for people with dementia and poor balance. That to me seems like maybe a coding, or maybe the doctor's note didn't specify why they needed the therapy.
Yeah, so someone sent in a question ahead of time. Why does insurance deny PT for someone who has dementia if they have poor balance? And Sanjay and I talked about this. It's likely a coding issue or a documentation issue, because insurance, and especially Medicare, they are not allowed to discriminate against somebody if they have a dementia diagnosis. So they outright can't deny a claim just because someone has dementia. It's really, so if they're being denied, it's likely something else. So the therapist is documenting something maybe that's showing the patient's not participating, or they can't follow commands, which then I would say is the benefit of coming to Powerback Rehab, because we are so neuro-focused, and dementia is a neurologic condition, and it impacts all the motor symptoms. It's not just about cognition. So when we're documenting, we're be very clear on the deficits, what the deficits are, how it relates to their dementia. We have a specific section on there that states whether the patient can follow commands. So we really work it so that we know that we're going to get coverage.
You'll see our therapists doing a lot of standardized testing, and that's so important. Everybody's like, oh, I just did this, but we do it to show that progress because Medicare has to see that, or your insurance has to see that progress is being made. So if we do a test once and then we don't do it again for 3 months, then they're not going to see that progress that's been made throughout. So we've got to make sure that we're showing throughout the sessions that we are making that progress. So we do hear complaints, oh, I just did this 2 weeks ago, but we have to make sure that we're showing why. And the standardized tests are designed to show the gait speed, the sit to stands, that strength that you're gaining in therapy. So everything that Kathy's working on in PT is being shown in those standardized tests.
I think we've kind of addressed this indirectly, but one question was, how is this therapy different from maybe the type of PT and OT that someone received at their skilled nursing facility for stand and transfer that maybe wasn't very effective for them?
Okay. So when you go into a skilled nursing facility, for those who don't know what that is, it's kind of like an acute rehab setting. So you went to the hospital, you had some sort of medical condition, you're not able to go home. You go to a skilled nursing facility where they provide rehab, and then you hopefully are going home after that point. So the difference, I would say, mostly between what we're doing is when you're in a skilled facility, the therapists are kind of the jack of all trades, right? So in the acute setting, they're seeing everybody. They're seeing hip replacements, knee replacements, someone who's diabetic, someone had a stroke. So they kind of have to be this jack of all trades. And their goal is just to get somebody home.
They only have a certain amount of time to get you home.
So insurance is strict. You only have this much time and you have to meet these goals. And they always want somebody to be in the least restrictive environment, AKA the least expensive environment. So they get kind of pushed out the door. So, and a lot of times after that, folks will get home health. Well, home health is just as restrictive. They've got coding issues. They got visa limitations. There's a lot of issues. Home health might only come in once or twice a week because we're considered an in-home outpatient provider. I want to make sure I said that right. We're considered outpatient. So we really, unless somebody's managed care, we really have no restrictions on what we're doing for patients here or in the home. We can see them 3 times a week. We can see them 5 times a week if we really wanted to. We kind of have free reign, and we can spend up an hour with patients too. One of the biggest complaints that I hear from people in SNFs, skilled nursing facilities, we call them SNFs, skilled nursing facilities and home health is therapist was only here for 30 minutes and I only got 30 minutes and they were done and they were gone, or they stayed on their iPad the whole time documenting. But when we see people, we are engaged for 60 minutes. So we're able to, in this case, this person is having an issue, it sounds like, with sit to stand.
Yes.
You said the question. So, what I would say is, when we're coming in, sit to stand is huge for us because with our neuro patients, that is something that everybody struggles with, is their ability to stand up. So we're able to come in and we're going to strengthen the right muscles in the right way. So we're not going to have somebody sitting in a chair and just kicking their leg. We're going to make them perform actions that are going to actually improve the function. That's just how, as neurotherapists, we're trained. We're not trained on an isolated movement because when you stand up, it's not one muscle working. It's your butt's working, your quads are working, the muscles here, fancy word, anterior tibialis is working, your back's working, brain's working, everything is working together. So if you just do these isolated movements, it's not actually going to help you stand up. So when we work with people, it's all about function. And a lot of stuff is about teaching people the right technique to stand up. The the biggest thing we see with people who don't want to stand up is they don't want to lean forward. Sometimes it's impossible to get people just to lean forward because they're so afraid that they're going to fall forward. So the fear of falling is really hindering. But because we can do all this stuff in a really safe way, and we're so trained with these conditions, we're better able to support people and give them the time that they need to actually get better. I can't stress enough that in-home outpatient or coming here, you really are going to get the best therapy, focused therapy. I know that's okay. That's okay.
Here's a great question. I'll take a stab at what my answer is when I get this question. I'd love to hear perspectives on it. But what do you do for patients with mild cognitive impairment when you tell them to exercise and they've never been a lifelong exerciser and they hate it and they say they hate to exercise? My short answer is there are very few things that we know will improve memory, and there are numerous studies that will show that even patients with moderate stages of Alzheimer's will show increased performance on word recall and various cognitive testing, even after as short as 4 to 6 weeks on an exercise program. Even measured within the same day, a cognitive screen in the morning, an exercise program for an hour, and then a cognitive screen right after the exercise has been shown that they can improve their test scores. So that's the way I present it. But when you meet people who say, I hate exercising and I don't want to do this, what's your approach?
We do hear that a lot. We hear, I've never exercised a day in my life. I don't want to exercise. But, we definitely reiterate the things that Dr. Iyer said, because to us, the research is solid. The research shows us these things. It is very clear what you need to do to achieve these goals. But then people think exercise is a certain thing. They think it's lifting heavy weights and, grunting and sweating. Of course, Beth is one of our athletes, so she's really great. She loves to be on the treadmill, but then people think about, I have to go on the treadmill and walk so hard and be huffing and puffing and sweating, and I don't like these things. And everybody has something they don't like. Like, I'm not a big weightlifter either. My way of exercising is not lifting weights. So we try to figure out what people like to do. And then we can incorporate exercise into those types of things. And exercise for us is more about movement and coordination and function. So, when someone says, I hate to exercise, but they can't stand up from a chair, and then we show them, well, if we move like this and we do this, you're going to be able to stand up on your own. They kind of buy into it. So a lot of times our first session is the selling point. We're like, okay, these are the things that we can teach you and get you to do. And then people are able to do it. It is rare that we have somebody that says, absolutely no, I'm not going to work with you. It does happen sometimes. Some people are really, really against exercise. And those people, I don't think anyone's changing their minds, but they're really rare. But there's a lot of, I don't like to exercise people. But the I don't like to exercise people usually get on board and they work with us and they have fun to do it. So when we go to someone's house too, we're not all serious and standing there yelling at people, come on, 10 more reps. We're not going to do that. We're going to push people, but we're also going to make them laugh a little bit. There's going to be a ton of smiling. It's going to be a really good time. And then they kind of look forward to you coming back, even if they are only exercising because it gives them an hour to hang out with somebody, they're exercising. And we somehow make it work. All of our therapists have really great personalities. And everybody's a little bit different too. But everybody is so pleasant and so kind. And, we just make it fun. And so people do it.
I was also going to say, we've got a great home exercise program through it's a computer-based system that we can go on and check to see that people have gone and logged on and done their exercises. So I have people that will send me a text, hey, did you look? I did my exercises today. So you have to find what motivates each person, because everybody's motivated by something different. So if they know that I'm watching them from afar, they're doing their exercises. So it really, and technology. Some people really like having the technology. Other people hate it. So we could print out this stuff, exercises too. But it is.
So yesterday was a beautiful day, and one of my therapists, her whole session with her patient was outside performing gardening tasks. But we kind of twisted and bended a little bit and make it therapeutic. But to them, they were outside. They do have a little cognitive impairment. To them, they were outside doing something really fun. The weather was beautiful, but, we made them bend down and stand up, many times. And I'm sure she did this, and doing different balance activities while they're performing a gardening activity. So gardening started a little bit early this year. So people are already out in the garden, and it was so much fun for the therapists too. So we like to have fun when we work, so we make sure that our patients have fun too.
One question that came in was, we always tell people who have some level of cognitive impairment, when they're at home, maybe work on crossword puzzles or read the newspaper, do things like that. Are there certain simple or common games that you recommend to people at home that are helpful, or things like Legos or other?
I saw that. One thing, a word game, I don't know if any of y'all play Wordle, but I've had a lot of people that we've started doing Wordle with, and really look forward to it. Some of them, again, will do it before I even get there. They're like, I already figured it out today. We don't have to do it. So I'm like, I'm glad that's motivating you to do something in the morning. When you first wake up, you're going on and you're doing Wordle. So if those that don't know, the word changes each day. So you'll have to go try it. But so doing brain stimulating activities. Yes, Legos. There's adult Legos now that have more like artsy. Kathy's getting better. Her son's really into Legos. So she goes to the Lego store a lot. But they have adult ones now that,
they have like artwork that you can make. The flowers. So we actually have flowers in our house that are Legos. It's really cute. But yeah, they're definitely gearing stuff more towards kind of adult Lego right now. And that's really great for fine motor, for following instructions, but also for the fine motor skills. And we love Legos.
You can find puzzles at the dollar store that do not look, they're 100-piece, but they don't look childish. They look for adults. So they're great ones to do that. Maybe it's not that 1,000-piece puzzle that we used to do or never did. But at least it's a great way for working the fine motor skills. It's a great problem solving. It's a great way to attend to a task. So
there's a question on there. Does Powerback have a limit on how long a patient receives services, even if insurance covers care? It really depends. That's definitely a depends kind of question, because it depends on your insurance. So people who have traditional Medicare, there's actually something in the Medicare regs that says that we can do skilled functional maintenance, meaning that we can kind of go on as long as the services are medically necessary and a skilled therapist has to do them. Now, managed care plans do not have that. Managed care plans are going to have a pretty strict limitation. So what happens though, and what we have to play around with, is an insurance company will come and say, you have 36 visits for, say, physical therapy. Well, that doesn't mean that I can give you 36 visits and they're going to pay me. It means that they're giving me 36 visits, but then they're going to review everything and then they might come back and deny us. So we have to always try to determine, is this a service that only I can provide to you, that a personal trainer, a wife or husband or caregiver cannot take over these services and provide them for us in a way that we don't bill insurance? And that is, if there's a gray area, it's really big. It's a huge gray area, right? So we have to kind of just balance what we kind of know about a certain insurance company, how they pay us and what they'll pay us for, and then we can kind of work through it. But we have no, like, we don't say we're going to see you 3 times a week for 12 weeks and then you're done, no matter what. We don't have that. Everybody is so different. It's completely different on every spectrum.
Can't believe I got to know.
Yeah, you're fine.
I'll see you tomorrow. For those of you who are
Thanks for
excited to come in person, do you guys have any questions or comments?
Address what she was talking about with the physical therapy for Parkinson's disease, and would it for a patient that just gets so rigid, and I know it's because he's probably afraid of falling, but it's just, and he's strong.
Yeah.
He's
Right.
really strong,
Yes.
which is amazing.
Yeah.
But would that type of physical therapy help him, like getting it out of the car,
Yeah.
walking down the steps?
Yep, absolutely. So we recognize that rigidity is one of the core components of Parkinson's. So it's part of the disease. Of course, fear of falling can definitely amp up the rigidity and make something really stiff. But we do, the program that I love most for rigidity is called Power Moves. It's a certified Parkinson's therapy program. And there's very specific exercises that are made to address rigidity. So it's a lot of rotational movement, postural instability exercises. And we just get somebody to break out of their rigidity through exercise.
Now, if this Parkinson's and also dementia, would the dementia inhibit what he would need to do in your therapy classes?
No, dementia just changes how we teach somebody.
Well, I'm just saying, I tried to put him in some Parkinson's physical therapy, and they said that he couldn't follow the directions.
Yeah, so we know that sometimes following commands is hard. Again, because we're going into this dual task, which we talked about. So it's hard for somebody to think something and do something. But what we do with them is we model everything. We show them exactly what we want them to do. We model it, do it just like this. And then most of the time, patients model back.
Mm-hmm.
But then we also put our hands on them. So Sarah also said, you got to put your hands on people. So, we'll touch them in certain ways that will guide their movements so that they don't need to hear a verbal command. I have a patient who, the more I talk to him, the less he does because his brain becomes overwhelmed. He has the Lewy body dementia. But if I say to him, do what I do, and I do a movement, then he'll do it. But if I say, take a big step forward, stick your hands out, and then take a big step back and put your hands back, and I start getting really wordy with them, they can't perform the exercise. So their dementia just guides how we teach them. And we just change it to fit their style.
So do we talk to our physician about if he thinks this would be beneficial?
Yes.
And then
we do need a physician order.
Yeah.
So but
and then would he come here?
So you have a choice. Of course, we're doing this because we kind of want to show off that we have this really great space. And I would say too, with someone who has dementia, it depends. Okay. Do you want them to have more socialization? So coming here is great because they're going to see other people that are kind of dealing with the same things. Or do they get super distracted by other people and they're not going to focus? Then maybe in-home is better. So it just kind of depends. And you can try both. So some people we see here one day and some people we see one day in their house.
And how far do you go?
That's a loaded question. It's generally speaking an hour around here.
We'd like to give a very special thank you to our superstar, Beth.
So thank you to everyone who's here in person. The perk of coming in person is that we have cookies. So take it off yourself. And for those of you on Zoom, maybe you have some cookies there. But thank you for joining us.